Good morning, everybody. My name is Jens Chapman behind this mask. Today is April 15, 2020, and I welcome you to our STED Talk today. Thank you for joining us. We have an interesting potpourri of cases, and two of our bright young fellows will present their research. I have no disclosures, certainly not pertinent to these presentations. We're obviously momentous times where our whole perspective on life, professional and private, changes. Terrifying contraptions have to be worn. The fashion statements look more like that of protesters a short while ago, but there's also amazing beauty and tranquility to be found. It's such a privilege to get to work here at the Seattle Science Foundation, where we've had a large number of productions through the Seattle Science Foundation TV. We have a weekly Spine Journal Club with a large number of very reputable centers from around North America joining us. We had a COVID-19 special hosted by Dr. Jeff Wong from USC. And just last night, we had an interesting case debate with our colleagues from Dallas, Texas, from the Texas Back Institute. From Cedars-Sinai, here you see Hyun Bae in the middle, and Dr. Alex Vaquero from the Rothman. We had 2,300 people join us live for interesting case debates. And we will offer this, so just go to ssftv.org to see our program. It's also a cool environment to be in because good things happen out of bad situations. Together with a local restaurant that we frequently partner with, the wonderful Babar restaurant, we initiated a 100 meals a day program for our healthcare workers on First Hill here in Seattle, where healthcare workers in the front lines, the ICU nurses, respiratory therapists, and support staff get free meals through donations. And this has found a very nice media resonance. And again, I see similar events now happening all over the country. I want to put a big shout out to our SSF TV staff with Dr. Skuyan, Lee, Linda, and Alexis. They're absolutely amazing to work with and have great ideas. Now, briefly, what are STED Talks? So this is something we came up with. It stands for Spine, Technology, Education, Discovery, Discussion, and Debate. The spinal column is an organ. It's not recognized as such frequently, but it sure is one. We look for advances in technology because we have to understand and know how to treat better our spine. Education is self-explanatory, and again, the act of discovery is one of recognition, research, and improvement, but it also entails discussion to compare, question, and explore, and finally to debate, which is a more substantive, repercussionate kind of a interaction where we try to substantiate, validate, and refine our thoughts. So nothing is fixed, and I hope you go to our extensive library of past programming at ssftv.org. Again, the spinal column is fascinating. It has all these motion segments entailed with it, and along those, we will start with our next and first case discussion. And I have kind of a problem with PowerPoint, so I'm going to restart PowerPoint here. And I do apologize. So, first I'll ask Dr. Lincoln Jimenez to come up, and he'll present us a T12 burst fracture case. And we have 3 brief case discussions to go over. Thank you, Lincoln.
Hey, good morning, everyone. My name is Lincoln Jimenez, one of the fellows at Swedish, Spine Fellows at Swedish. Today we're going to discuss multiple cases, but this one is quite interesting. A patient that was treated back in 2017. In this case, it's a case that I named it as a traumatic burst fracture in an osteoporotic patient. At that time, when the patient sustained the trauma or the fracture, the osteoporosis was not known on her. However, this patient is a patient that was actually initially seen somewhere in the Caribbean, and then she was transferred down to Seattle. This case is a case of a 57-year-old athletic female She was transferred from a Caribbean island on 4/6/17. She sustained a diving injury while on vacation. She was actually pulled from a natural pond at that time. Unfortunately, of course, the patient did sustain some changes in the neurological examination that we thought it was pretty much a spinal shock just based on the reports from the country where she came from. She was imaged at that facility, and she was found to have a T12 burst fracture with compromise of the canal. Pre-hospital management in the Caribbean was pretty much immobilization along with bed rest, and she was started on IV steroids. She also, just as a past surgical history, had some left hip replacement, but other than that, not much of a significant medical history. These are kind of like the original images. The ones on the left side are the ones that came from the Caribbean. The one on the right side actually is one that was taken over here upon arrival, and she had a brace in place. What we see here is pretty much a T12 fracture with some changes in alignment. There's also right here, I tried to get actually the stereo image, but unfortunately I couldn't. But this pretty much tells us that there's also some chances of ligamentous injuries at that level. But once again, she did not have much of a big alignment issue going on at that time. Here is the image, the first images that were done at Swedish, as we see, there's not much of a big change compared to the images that were taken from the transplant hospital. The fracture, once again, is, I can't see here, but I don't know if you guys can see that, but the fracture is, there's not much change in the MRI from the transplant facility and to us. At this time, we classified this fracture as an A3 type fracture. There is, as we can see in this image over here, there is a canal compromise of about 50% or more right here. And that could have been the reason for which she was actually having some neurological issues, such as decreased sensory as well as decreased motor function. This was something that was done back at the time. We actually measured the Hounsfield units, and we found that they were below the 120 level or 100 level. It just depends on where we take it from to consider it potential for osteoporosis. Intraoperatively, pretty much what was done is to identify the level of the fracture. As we see here in the first slide on the left side, we see that there is a Woodson trend localized exactly the space in which we're going to go. And then as we go with the procedure to try to resect that disc, and then we put a PIC cage at that level. And then after that, we decided to do a short segment instrumentation, T11 to L1, including the fracture level. This is the first image postoperatively. At this time, the patient does have a brace in place. This is the immediate post-op image. And after the patient had surgery, actually, she did have a very good recovery. Within 2 weeks, the patient was actually ambulatory, and if I'm not mistaken, the patient had already started the process to go back to work. On discharge, it was recommended patient, of course, follow up with the primary doctor, and also she was requested to have some evaluation of bone density, which she did. And when comparing the CAT scan, we found, of course, that the patient was found to have a osteoporotic fracture. Osteoporosis along with the traumatic burst fracture that she has sustained. From there on, all it was just a follow-up images. We can see from the right to the left how the images have progressed. The first image on 4/17 is the first image after she had the surgery with a brace. Later on, we can see that there is mild progress in subsidence of that kyphosis at that T11 to L1 level. However, she has not actually progressed that much, and clinically she has done very well. The last time that she was seen was early on 2019. At that time, the patient was only complaining of right hip pain. One thing that I forgot to tell you in initial slide is that she has history of left hip replacement, and she was actually being worked up for right hip pain, which was not related to her to her spine surgery. And once again, I just mentioned here that she had minimal subsidence. So the questions we had based on this case was, have we been too aggressive? Have we not been, have we decided to do a long construct? Would it be different? Are we going to have the minimal subsidence that we're seeing right now in this patient? That's something that, of course, we decided to evaluate, and in reality, there's really not much about it. But I came up to an article regarding the effectiveness of short segments, and actually they did a review, and what they found is that in reality, in patients with traumatic burst fractures or traumatic fractures, there is a good chance that with a short segment, provided there's no major alignment issues, there's a chance that these patients do have a good recovery with no major changes in alignment with progression. So the other thing that was interesting is that the authors recommend here for patients with short segment that if you are able to put actually a screw at the fracture level, that will actually increase the chances of stability and decreases the chances of alignment. The only thing that I have here to say is that, for example, in this article where they did the review, they never included patients with osteoporosis. The other thing is, should we have used a different expandable cage rather than the static cage that was used at that time? That's also a possibility. However, studies that are currently present, they do not see any major advantage of using a static versus expandable cage. Not sure if you guys have anything else to say.
Great. Thank you, Lincoln. Yeah. And you preempted our question also. Do you have your mask? Yeah. We'll show a quick CME slide so that we do our due diligence, and I'm going to switch the talks. That was excellent, Lincoln. And again, you brought up some of the main key points. This is a burst fracture patient with neurology. She's very osteoporotic. To rebuild the spine, we have to somehow do something with the neural decompression. We have to stabilize it from the back, and we have to try to find a way to rebuild the front. And that was done in a short segment fixation there. She did have some subsidence. I'm looking for your talk, and I can't find it right now.
I think power point crashed. It crashed as well, so I can
So,
try and...
is there a slot over here? Or you have to pull it out from here. So the key elements and the concern in these three cases that you're going to see very rapidly presented are how do we decompress the spine, how much do we stabilize, and how do we rebuild the front of the spine, which is the main weight-bearing thing. To show that from a different angle now, Dr. Ryan Goodmanson is going to present a case that he's been recently involved with. Ryan.
All right, thank you. So, in keeping with a similar theme, we'll talk about this person. This is a case of JR. He's a 71-year-old male who sustained a ground level fall somewhere around 2 weeks prior. He was being treated by his primary care physician kind of on an outpatient basis, and due to the crisis that we have, he's actually being treated in kind of a drive-through clinic, unfortunately. He slipped and fell. He was having a lot of back pain. He started to have more difficulty with mobility, ambulation, and was having some urinary incontinence, although this was something that was not necessarily new for this patient. But this increase in his bilateral leg, groin pain, and worsening back pain with rest prompted some continued treatment and workup by the primary care physician and eventual transfer to our facility. So, just to go over his history, he has quite a bit. He is not necessarily the picture of health, and tried to highlight some of the things there that are significant, being he does have myasthenia gravis. And they thought he maybe was in a crisis for a while, and he's been treated on chronic steroids for this. He has a surgical history of posterior cervical fusion. He's had a DVT in the past with a greenfield filter. Something of note is he does have a jejunostomy tube, which made it a little bit difficult to treat him in a brace by his PCP, which they were attempting to do. And before all of this, he was actually able to perform all of his activities of daily living fairly well. On physical exam, he did have just kind of generalized weakness, but there was really no focal weakness that could be elicited on this patient. He did have clonus in his bilateral lower extremities, and a hyperreflexic patellar tendon reflex on the left-hand side. These are his labs just for completeness sake. Originally, he did get an MRI from his outpatient facility, and we'll look at that. But in talking about this, CT is a better way to look at a fracture in these patients. This patient did have a fracture of the L2 vertebral body. Let's see if I can get this to play. Sorry. Don't know. Oh, I'm clicking on it on mine, but it's not clicking up there. That's weird. It's like an inch off. So he did have an L2 burst fracture, which was complete, and we'll talk about that in just a second. With retropulse fragments, probably about 75% height loss, a little bit of local kyphosis in that area, and probably 50 or more % of canal compromise. Here's his MRI of the same thing. This was what was obtained originally by the primary care physician. And you can see again this fracture as well as the canal compromise and thecal sac encroachment there. So something we talked about a couple weeks ago actually were our Hounsfield units for the measurement of osteoporosis, and Dr. Jimenez actually touched on this a little bit. His mean Hounsfield units, if you measure him somewhat globally, are around 114, which is a little bit low. If you look at some of the literature that we talked about before, around 110 is osteoporosis, around 135 is osteopenia. Some people suggested augmenting screws at about 120, and around 86 is where he had a high significant risk for vertebral compression fracture. So if you look at him, he is trending towards osteoporosis, definitely osteopenic, and probably should have some augmented screws. So as one of my very wise colleagues said, when you have a fracture, you always review the classification system. Dr. Quintep, the AO master. So this is a A4 type fracture. So it's a complete burst fracture. It goes through both of the end plates. And so this is likely a surgical type fracture. So here is his fracture kind of superimposed there, so we can see that. So due to the current crisis, things were a little bit delayed, but we were able to figure it out, and we created a treatment plan for him. He was unable to mobilize in any of his braces. He was continued to have pain despite his conservative treatment, medications, physical therapy, and so this was a patient that we felt needed some sort of stabilization. So the plan was to go 2 up, 2 down, basically T12 to L4 with instrumented fusion, a partial corpectomy at L2, and then do a decompressive laminectomy as well. We were able to accomplish this fairly well. I'm sorry, I can't see my cursor. There we go. We were able to accomplish this very well. We did augment screws through a fenestrated screw type approach. I think that the alignment has been restored, as well as a good reduction of the fracture. Little bit of critique is maybe we could have disimpacted a little bit more. However, we did do a wide laminectomy at that level. And there is still, this is still kind of a process. So our question is, what's the next step for this guy? Because he is very sick. He does have osteoporosis, osteopenia turning on osteoporosis. Do we go back in lateral and do a full corpectomy and augment his anterior column? Or do we let him sit as is and kind of keep going? So this is just a little plug. Tune in Friday because we will be having a journal club that will kind of go over some of this and other articles from our colleagues at Rush.
Awesome. So go back to the slide,
Yes, sir.
The last picture slide of the postoperative reconstruction. So ask Dr. Oskuyan to maybe come up front and just talk about, can we leave this burst fracture now that we have an exceptionally strong anchor of 2 above and 2 below alone, or should the anterior column be reconstructed?
So there's a couple really nice papers, but the question becomes, is there's going to be a lot of remodeling of that fracture, and usually when it remodels, it kind of resorbs. But it's going to be a race between how mobile and how weak his bone is, and how much collapse you get. I think I know this patient pretty well. He's not going to be running around town. So I would probably get x-rays in 6 weeks and then a CT scan in 3 months, and you can always go back in. What do you think, Jens?
I don't know, this is a tough one. I mean, this is a very nice reconstruction. These are newer implant systems that were used. You did a very nice job. He's getting up and around much better now. I saw him mobilizing quite well, which he did not do for 3 weeks of inpatient non-operative care. I don't know, this is a tough one. I think I would probably err on the side of replacing the vertebra just to make it bulletproof. But again, this is an open question. What are you thinking you're going to do?
I've always been taught that anterior column support is needed. Again, this is a fracture, and so it's probably going to heal, and that is bone graft. It's autologous bone graft that we pushed up front. However, with his osteopenia, I'm not sure that, again, he's going to heal that. So like you said, it is a possibility we can at least go back in. For now, at least, he's stabilized and able to mobilize. So
Great. Thank you for showing us this case and sharing this. And to show another perspective, we've asked Dr. Ben Schell to come up. And Ben, where would I find yours? Is that case 3?
No, I think it got closed as well. I have to do some fancy.
So we can show our CME slide again in the interim.
Oh, we're good.
Oh, he has it. Never mind. Dr. Ben Schell, originally from Kentucky and then from Dallas, Texas.
Very good. Thank you for the intro. Ben Schell, I'm one of the other spine fellows here at Swedish. Did my training down at Dallas, UT Southwestern. So kind of the third, to complete this narrative arc, a third case, again, another burst fracture, another way to treat it. And so you've probably heard a little bit of this story before, very similar to the case Dr. Goodmanson just presented. So 79-year-old male, had progressive low back pain, radiculopathy for about 3 months. This was actually pre the COVID crisis. So he was seen at some outside facilities, kind of bounced around, didn't make his way to us until 3 days after a fall, and we were called by an outside hospital up in Northern Washington, and with images that I'm about to show you here in a second. Once he arrived to see us, this was his exam there on the right. And upon talking to him, he had 3 weeks of urinary retention with some incontinence and some buttock numbness once you elicited him, and then just some relevant past medical history for him. Relatively healthy guy for an 80-year-old. He was a former smoker. He had a history of prostate cancer that had been treated, and probably the most relevant thing for us as spine surgeons, kind of in a social history, the Jehovah's Witness, that's his admission, H&H there. And so that's always something that we think about, surgical planning, especially stage procedures. Is that going to affect things? And then we have a lot of discussions with these patients. We can kind of talk about that as we go along. But this exam there, hyperreflexic in the lowers, and then some weakness as well. And so here is his CT scan on admission. You'll see the burst fracture here at T12. He does have some transitional lumbosacral anatomy, and so in some of the radiology reads and then some of the scans themselves, they call it L1, but we, through all of our counting and then all of our radiologists here, called it T12. So we stuck with that nomenclature to call it T12, the T12 burst fracture. And then here are the relevant MRI scans, the STIRs there on the far right. These were all, again, sent from the outside hospital, kind of as Dr. Gibson alluded to. The CT scan is the preferred imaging modality when you have these fractures to really elucidate how much bony impaction has occurred, where the bony injury translates through, if it's going all the way, through the lamina, like we heard in a case presentation last night, that you really need to find that out. I mean, the MRIs are very helpful, especially here where it's kind of at the conus and he's having some symptoms of urinary retention and buttock numbness. So there's the imaging there. And so on the next slide, just talking about a plan. What do we do here? We do have an 80-year-old guy, relatively healthy. He is a Jehovah's Witness, so we have to kind of be mindful of blood management. We have to be mindful of length of surgery in the elderly population, and we have to think about a lot of things, and that's one of the fun, interesting things that brings a lot of us to spine surgery, is that everything matters all the time. And so we went with this construct shown here, some intraoperative shots from the first surgery. I apologize that one on the right doesn't show up great. But so I wanted to highlight a couple things from the intraoperative shots. That image on the left is what we kind of use a thicker, almost a 90-degree or thicker Woodson, and we are able to push forward and impact some of that bone graft. You don't want to take that out, as kind of we talked about with some of the fellows, after the case discussions last night with Dr. Chapman, that you risk taking that bone out and getting a dural tear anteriorly, and that's kind of the last place you want to have it. So you want to push that bone graft forward. It ends up being, a good bone graft to support that anterior column. So you push it forward, take the impaction off the thecal sac, and then free up some space in the process. And then, as Dr. Jimenez talked about, you put a screw in that in the fracture vertebrae as well, and it gives you a little extra support. And then we did it on the right side to allow for the stage procedure to do the left. So what we did was the originally posterior part of the procedure on a Friday. We did this construct. This was an open procedure, extended 2 levels up, 2 levels down, and then had 250 cc's of blood loss. And in light of how well he did, obviously no transfusions, given he was a Jehovah's Witness. We did the cell saver as well. Everything went fine. During the surgery, neuromonitoring-wise, there was a small traumatic dural tear from the impaction that was repaired uneventfully. And then, given how well he did from that, that was on Friday. We went back on the following Tuesday for this procedure. So it was a lateral, left lateral, finished off the corpectomy, and then did this expandable cage. Again, everything went well. Less than 100 cc's of blood loss here, no transfusions. Felt like the construct was stable, and no neuromonitoring changes there. And then here's the post-op CT after both procedures, showing the restored alignment and the height. I was there for both surgeries, so I think it was a great cage position, but I'm biased. And then we'll talk about a couple of things we could have changed here on the standing films here in a second once this scrolls through. So again, important things to remember for this, given his Jehovah's Witness, clean, dry, precision exposure, be quick, but don't hurry. You want to be efficient. He's 80, he doesn't want to be, you don't want him to be under anesthesia longer than he has to be. But then you do want to do what's right for the patient, and you're already in the surgery, so you want to make sure you do everything you came to do. And then here are standing films at 3 months post-op. Same films there. So we just had a virtual phone visit with him. He's doing well, getting up, ambulating more, back pain's decreased. Otherwise uneventful post-operative recovery. And so then a couple questions to kind of talk about. Given that he is 80, given that he is a Jehovah's Witness, is this too much surgery? Some people could argue that maybe we should have done a smaller procedure, one up, one down, try to minimize blood loss even further. And I think my counter argument would be that, we kind of glossed over this in the beginning, but his Hounsfield units, the 2 levels above and 2 levels down, or 155, 160 above, and then 171, 174 below. So I don't think, his bone was so weak that we would have had to, do something different. So I think this was the right amount of surgery for him. I think staging it was appropriately, given that he was a Jehovah's Witness and we didn't know how much blood loss we were going to lose. So by going in and saying, hey, look, this is the right, this is all we're going to do today, it kind of takes a lot of pressure off everybody to try to force it, try to move faster, or try to do something heroic on somebody who doesn't have a lot of reserve to begin with. And then as far as cement augmentation, kind of like touched about with the Hounsfield units, we didn't need it. Felt like his Hounsfield units were high enough, and that intraoperatively his bone quality was solid. And then we got good purchase with all our screws. So we didn't feel like we needed it at the time. But again, I think those are all 3 points for discussion, all 3 points for criticisms that we can talk about.
Thank you, Ben. That was a great case. And as I'm going to pull up the next talk, just maybe stay around here. So in terms of the cementing, now that you've seen a cemented case, where do you see the role of a cementing in a patient like this, and then not having to do that second surgery? Could we have cemented him and then just left that burst fracture by itself and let it heal?
I think that's a totally reasonable option. I think the cement, especially with those fenestrated screws, I haven't used them yet, but they look great. And from the ease of putting them in, or the other way that we've done it, where we inject them with the Jamsheedes and then follow that with the normal screws, where it gets a better good bite within the cement itself. I think those are all good options as far as screw pull out. But just from what I've seen here, I think in my practice, I'll be more apt to do the anterior column support.
All these 3 cases, while they had major surgeries done, actually had really failed all attempts at non-operative care, and were really kind of very desperate. And you see a lot of hardware putting in. How to put in hardware precisely is an art, and has been an art, aided by some technology. But now we're at a step in time or point in time where there's probably a transition where technology can help us. Now 2 research projects, and one is by Dr. Bilal Ketaneh, one of our great fellows. He's from Jerusalem, Israel. He's going to talk about how new technology can possibly make it easier and more precise for us to put all this hardware in. Bilal?
Good morning. I will talk about intraoperative 3D imaging in multi-level posterior spine fixation for pedicle screw placement verification. No conflicts of interest related to this study. As we all know, pedicle screws were first reported by Bocher in 1959. They are essential component in posterior spine reconstruction surgery. They provide 3-column support. Insertion can be challenging, especially in deformity cases, revision cases, and when we have small pedicles, type C cortical. There are various techniques to increase the accuracy of pedicle screw insertion, including robotic and navigation. But the problem, not all the operation room have this advanced technology. Malpositioned pedicle screws can have neurologic injury, vital organ injury, and suboptimal biomechanical fixation. Assessment of pedicle screws placement can be intraoperative by X-ray, 3D fluoroscopy, or CT, or postoperative by X-ray and CT. And the problem with postoperative assessment, if we have symptomatic malpositioned hardware, we have to go to revise. There are innovation in medical imaging enabled us to do innovation medical imaging allow us to appropriate assess pedicle screw placement. There are first generation 3D fluoroscopy and second generation 3D fluoroscopy with the difference in image quality and radiation dose. And there is also intraoperative CT. Our hypothesis, intraoperative 3D scans reduce the rate of return to OR from malpositioned pedicle screws in multi-level posterior spine fixation. Materials and methods, it is a retrospective observational study from December 1st, 2018 to November 30, 2019. Inclusion criteria, multi-level posterior spine fixation, use of intraoperative 3D scans, ZIM, at least 3 months of follow-up after surgery, freehand pedicle screw insertion with the use of X-ray fluoroscopy guidance. Primary outcome, return to OR due to hardware misplacement. Secondary outcomes, number and location of the screws revised, intraoperative complications, and if we have false negative intraoperative 3D scans. Variables collected include demographic data, indication for surgery, level of surgery, history of previous spine surgery, total number of screws inserted, if we have a post-op CT, and after doing the 3D spin, the number of screws that are repositioned or removed, the location of the repositioned removed screws, any intraoperative complication, grading of the malpositioned screws, grade 0, no pedicle perforation, grade 1, only threads outside the pedicle, grade 2, core screw diameter outside the pedicle, grade 3, entire screw outside the pedicle, and also the direction, if it is medial, lateral, superior, inferior. Secondary revision surgery due to malpositioned screw, and in patients with post-op CT, number of screws with significant malposition, more than 2 millimeter breach, and not identified with intraoperative 3D spins. Results, 114 patients included, 6 patients excluded, died from non-related causes. Mean age was 64, range 27 to 85, 1,315 pedicle screws inserted. Levels of surgery, 41 cases, cervical proximal thoracic, 73 thoracolumbar. In cervical proximal thoracic, the main indication was degenerative or deformity. And also in the thoracolumbar cases, the main indication was degenerative or deformity. After doing the intraoperative 3D scans, 20 pedicle screws were changed in 10 patients, 1.5%, which represent 8.8% from the cases. No intraoperative complication due to malpositioned screws or repositioning of the screw. After doing the intraoperative 3D scans, in addition to the pedicle screws, we have 273 cervical lateral mass screws and 96 pelvic screws, and none of these screws were repositioned also. Here in the intraoperative 3D scan, we have medial breach to the canal, and in the post-op CT after repositioning of the screw, it is well positioned. Also in the intra-op 3D, we see lateral breach more than 2 millimeter and post-operative CT after repositioning. Distribution of the screws that we changed after performing the intraoperative 3D scan, we don't have a specific location, it's distributed in all the levels. Also, the reason for repositioning, usually more than grade 2, which is 2 to 4 millimeter, and medial. Results: no return to OR due to malposition pedicle screw in all of these patients, and no intraoperative complications. In patients who have post-op CT, in 87 patients with additional post-op CT, which represent 76% of the patients, 14 screws were grade 2 breach. All of them were asymptomatic and accepted on the intraoperative 3D scan. Return to OR due to hardware malposition in our institution in 2016, it is 2.3%, 2017, 0.66%, 18, 0.39%, and 19, 0.65%. In 2019, in all these cases, no intraoperative 3D scan was done to verify the placement of the screws. Also, in 2019, we have 2 cases of single-level hardware malposition. In the previous years, 18, 17, 16, all the cases were multi-level. So in conclusion, intraoperative pedicle screw placement verification with a routine intraoperative 3D scan may be considered in patients undergoing multi-level posterior spine fixation, as it can reduce the secondary revision rate for malpositioned pedicle screws. Thank you very much.
Thank you, Bilal. I'm going to keep my mask on because I'm close to you. Also, that was a very nice project. So what have you learned from this? This is an expensive technology. It takes about half an hour extra. Is it worth it?
What I learned from this in multi-level cases, especially deformity revision, I think it's worth it, especially if it takes now half an hour. When you retake the patient another time to the operation room, it is an added morbidity cost to the patient. Okay.
I'm going to go to Dr. Oskoyan. Dr. Oskoyan, do you think that this should be done routinely for posterior instrumentation cases?
You know, that's a great question because it brings up a lot of issues. So one is, you know, how useful is navigation if your revision rate is so low? The second thing is, I think not all centers are equal. So I think if you're doing a lot of revision instrumentation cases, I don't know the answer, but I was going to ask Bilal, you know, I know you looked at, you said 2/3 of the cases had as well post-op CTs?
Yeah, 75%.
And I think the screws, again, you didn't detail it, but there were some, like, for example, C2 pedicle screws, and I think anatomical location was also a factor. I don't know the answer to it, and you know, there is I can't remember the exact number. I think it was like, for each case we have to bring back to the OR, it costs the hospital over $66,000. So I do think there's an opportunity there. I just don't know what, you know, and the other issue with the Zeems, Bilal, I don't know if you want to talk about, but it's an excellent fluoro machine, and because we only have one of them, we're not, and everyone's using it to spin, we're not allowed to use it as a fluoroscope. What are your thoughts on the Zeem versus a standard machine? And then do you think this is better than navigation?
About the Zeem, I think it's an excellent portable machine that provides good image quality, and there are many researches about the radiation dose, which is acceptable. I think I would use the Zeem, especially when I do freehand technique under X-ray. From this research also, I conclude that in patients that I use the intraoperative 3D for verification of screw placement, I don't think there is a need for postoperative CT if the patient is asymptomatic, because we already did an intraoperative 3D. Okay.
Excellent, thank you. And thank you for sharing this. Oh, I just did something bad, but I'll restore it. Along the same vein, we saw how we restored a patient's spine with a cage in 2 of the 3 cases. Dr. Cliff Pierre has looked at how we can restore the spinal column from the backside, not having to come from the front, and has some interesting insights anatomically and biomechanically. Dr. Cliff Pierre?
Good morning. My name is Clifford Pierre. I'm one of the fellows here at the Swedish Neuroscience Institute and the Seattle Science Foundation. I'm originally from Brooklyn, New York. I completed medical school at the University of Rochester and started neurosurgery training there. As Dr. Chapman noted, today I'd like to discuss one of the projects I've been intimately involved in here, and that specifically was focusing on in the Bioskills Lab here at the Seattle Science Foundation doing a cadaver study, studying the anatomy of the 3-column intradiscal osteotomy. And personally, I do not have any conflicts of interest. However, I do wish to disclose that material support and testing for the biomechanical study was provided by Globus. Giving some context and background, as we discussed from some of the earlier cases today, any reconstructive surgery, more specifically for adult spinal deformity, it can involve some surgical techniques such as the standard pedicle subtraction osteotomy or the vertebral column resection. And both of these procedures, literature has shown as well as experience that there can be quite a high rate of complications associated with such. Therefore, this leads me to introducing one technique that we do commonly here is the 3-column intradiscal osteotomy. And with the different type of cages that are available to us today, one of the things I wanted to focus on throughout the year with this anatomy study was not only understanding the relevant anatomy associated with doing this procedure around the disc space itself, but also the biomechanics involved with the types of cages that can be used. A deeper dive into the intradiscal osteotomy technique. Here on the left, the orange shaded region discloses the area of focus with this procedure itself, that being the resection of the disc space as well as the posterior elements, the lamina and facets. The figure on the right, Dr. Ramey and our group published in the World Neurosurgery Journal, a sort of a classification that we use here commonly to discuss some of our resection while doing the bony decompression. So removal of some of the posterior lamina, we do an inverted U-cut as well as a T-cut, and this is something that we discuss closely when we doing this procedure. Using some of our instruments. We often used a high-speed bird drill in doing some of these lamina cuts, and on this next slide, we discuss further the intricate parts of the intradiscal osteotomy, that is removal of the posterior edge of the superior and inferior end plates while completing the rest of the discectomy. Prior to inserting interbody device, we can release the anterior column if needed for the particular procedure itself, and often beforehand we would do posterior segmental instrumentation prior to doing the resection for stability. And then once we are pleased with the resection itself, and after placing our interbody cage, we can do compression with the rods and get further distraction at this level. In the lab, one thing we were able to do with the cadavers is inserting K-wires after doing a posterior midline incision and exposing the area. We exposed the intervertebral disc space, inserted K-wires on the fluoroscope, and then did different measurements of the certain vital organs, such as the kidneys, colon, as well as the lumbar plexus. Using microcalipers, we were able to measure the distance from the disc space to these structures itself, and so that was one of the focus of the projects. And while this table is a bit busy to read, one of the things that we were able to appreciate at each of the disc space within the lumbar region, we were able to obtain mean measurements from the cadavers that were used. For example, at the L1, L2 intervertebral disc space, we noted that the mean distance was about up to about 2 centimeters from the kidney itself to the particular disc space at that level, and then it increased at L3, L4 to about closer to 3 for that. So that was one of the things we were able to discuss. The second half of the talk, again, going further into the biomechanics, again, with the material support provided by Globus, we did 3 different subgroups. Again, this was comparing subsidence rates as well as lordotic correction and disc heights for expandable interbody devices, static devices, and compared this to using a Smith-Peterson osteotomy technique, a T-lift cage at that level. And so those were the objectives. Brief overview of the study design. We did 9 total lumbar specimens. We did mono segments of each of those lumbar regions, so that's from L2 to L3, as well as L4 and 5. And using fluoroscope, we were able to, complete our dissections as well as insert our cages. We inserted an expandable cage, static cage, as well as a T-lift cage. These are AP and lateral shots of the 3 groups that we did. We had 18 segments, and this is a result slide of the motion metrics. One thing that we were able to appreciate was that the range of motion for all 3 groups with specifics to flexion and extension motion, lateral bending, as well as axial rotation was the same for all 3 groups. There was no difference pre or post subsidence for this group. For the expandable cage group, we noticed that there was a larger loss of stability in that there was more motion for each of the 3 motion planes that we were studying. We noticed that motion was significantly higher for the expandable group. And when comparing it to the SPO T-lift group, we noted that there was significantly higher motion in the lateral bending after subsidence. And that was one of the major highlights of this portion of the study for the motion metrics. Studying the subsidence rates after loading in axial compression. Here we see a diagram of how the segments were loaded onto the actuator. It was a weight of about 112 pounds that was loaded axially onto this. And the cyclical loading occurred between forces of about 400 newtons to 1,200 newtons. And what we did was the measure of subsidence pre and post using x-ray was 2 millimeters was our cutoff. And so what we noted was that there wasn't any statistical difference between the subsidence rates. However, we did note that there was a change from the expandable to the T-lift cages. So the take-home message again from thus far was that there was an increase in subsidence that was seen with expandable cages, and there was increased motion in all 3 planes for the expandable cages. Now, further studies of the lordotic correction with these 3 groups, we noted that in the postoperative phase after subsidence, it was similar lordosis for all 3 groups in our study. There was a much more significant loss of lordosis in the T-lift group as compared to the other groups. When comparing the disc heights, we also noted for the expandable and static group, there was about a loss of disc height for about 2 millimeters in each group. And so the take-home message from that was that, again, subsidence results in a loss of disc height and lordosis, especially for the expandable group. And putting it all together, again, range of motion was the same, noted for all 3 groups of our expandable static and the T-lift cage, and there was increased motion for the T-lift cage, more specifically for the lateral bending motion. And again, we noticed that there was a similar postoperative loss of disc height for all 3 groups. Now, using further discussion with the biomechanics for these cadaver studies, one thing that we wanted to study was, again, why did we see such results with the intradiscal osteotomy? And now one thing, as we appreciated, was that potential placement of the cage itself within the disc space could be a result for the subsidence that we saw. And so any further cage settling, if we noted that if we placed the cage more eccentrically or laterally, this would probably probably help avoid some of the subsidence rate that we saw specifically for this group. We also noted that could there have been any overexpansion while doing the compression for the monosegments, because some of the things that we note, more specifically for lordotic correction in our clinical experience, we see that we can get more lordotic correction with some of the cages that we use compared to what we saw in the cadavers. Reviewing a case and example, here we have a 70-year-old male who had underwent prior surgery, had a 5-1 discectomy. We did a intradiscal osteotomy procedure. Overall, we did an L3 to S2 revision for a low back pain as well as right leg pain after the patient had failed multiple rounds of conservative management. And so these are the images preoperatively, again, with some noted measurements of the pelvic parameters as well as lordosis globally and segmentally for this patient, and postoperative imaging at 12 months after doing the intradiscal osteotomy procedure at multiple segments. We did notice an increase in the global lordosis for this patient overall, and again, just further conclusions, as we know we're near the time ending of this session. One of the things we can appreciate that further knowledge of not only the vital organs such as the neurovascular structures surrounding the disc space when doing the procedure can, again, make this intradiscal osteotomy an alternative technique that surgeons can use when considering comparisons to some of the other more invasive techniques for adult spinal deformity correction. And using different cages, such as the expandable or static cages, can provide biomechanical support as well as correction, we noted, for the intradiscal osteotomy procedure. We believe that, again, further clinical studies, which we're undergoing right now, comparing static and expandable cages in our institution, is underway to further elucidate that information with regards to cages and intradiscal osteotomy. Any further questions?
So Cliff, I have
Yes.
a couple questions for you. That was a great presentation. Can you go back to your, three main questions is that, one is, can you tell me how much of a difference, or did you guys not look at this, was there between doing expandable interbody versus a static? Was it a couple degrees? What was the difference in height?
Yeah, there were a couple degrees. One of the things we noted again,
Or millimeters?
So for the with the lordotic correction, expandable versus static correction, there was about a degree, at least with those monosegments, of up to about 5 to 10 degrees at each of those stages between expandable and static. This was the range that we noted here, but overall it was about the same for all three groups. One of the things that we figure from this was not only just sample size of the cadaver specimens that we were using, but also just the difference that you can get for segmentally versus a global lordosis. We weren't able to appreciate that using a monosegment with the lumbar spines.
Okay, and then the second question is that, did you guys see, was there more instability with the expandable? Or do you think, why would you have more subsidence with the expandable?
We did see that there was probably an increased loss of stability with the expandable versus not. We believe, again, with the increased motion, therefore indicating possible instability at that level, we saw that there was more with the expandable versus the static or the other cages. And we believe, again,
How did you test that?
How do we test that?
Yeah. Can you go back and show that?
I can go back.
Is it subsidence?
So we noticed that there was an increased subsidence.
Okay.
And we believe, again, part of that was likely placement of the cages itself and sort of location, placing it more laterally versus centrally. So we believe that there was more cage settlement placing these cages centrally, which could have led to that result overall.
And then the third thing is, let's say now that you have the results, what's going to be your hypothesis, or what are you recommending for surgeons that are doing intradiscal osteotomies and they're trying to decide, do I use a static cage or do I use an expandable?
So right now, based off the results that we were able to obtain from the cadaver study, I think recommending for the amount of correction that you likely would need and minimizing any rates of subsidence, recommend expandable, static cage versus expandable, and also being mindful of the location of the cages would be quite crucial for either types. And so that's what we would recommend at this time.
So how about, can you make any conclusions on, would you use cross connectors, and would you increase the sizes of the rod or diameter of the rod?
So one of the
Quad
things.
rod or?
We wouldn't necessarily, depending on the type of procedure that you're doing, the size of the rods versus as well as the distraction on how much dynamics that you need, change-wise at that level of which that you're considering, that would be something to consider, because that's one thing that we do believe, the amount of compression, did we overexpand or distract with that? And so being mindful not only cage and how much distraction that you need would be some of the factors to consider when doing the procedure. Now, when considering quad rod or cross connectors, that's something that we'd have to further study. But if that provides more stability or fixation points, that would be highly recommended.
Great. Thanks, Cliff. So this is going to conclude our STED talks for the week. And then we have a journal club, I think, on Friday. And the journal club was so successful last night. We had like 3,000 people log on. So the content and the expert reviewers and the different institutions. So I think we have Cedars, Rush, Thomas Jefferson, Texas Back, Hospital for Special Surgery, and USC. So we have a lot of different institutions this Friday. And actually, we're going to kind of continue on and talk about some of the themes that we did today, like, for example, burst fracture, do you go anterior column support or not? So I really appreciate everyone, and thanks again for SSF for setting this up, and look forward to seeing you guys on Friday. Thanks, everyone.